Well, with the recent news of President Biden's prostate cancer diagnosis, many men are wondering if and when they should be screened for prostate cancer. It's a very important question, and I'm glad more people are asking the question. Screening is the very first step of the conversation within the world of prostate cancer. We typically recommend starting the conversation at the age of 50. This should be earlier, importantly, if you have a family history of prostate cancer or are of African American race. Family history, importantly, is not just any male family member. This is typically your father or your brother. Family history also should be not just considered for prostate cancer alone. It should be in men who have a history or a family history of breast cancer and melanoma, as these cancers have common genes to those of prostate cancer. A big misconception within screening is that screening leads to treatment, or it is always with the intent of treatment, or with the intent of performing treatment. But that's not always the case. Screening is often just information so that one can better risk stratify a patient in order to truly make an intervention when it matters for that patient. Screening does save lives. This is well documented and well studied. It helps us catch cancer early before symptoms appear when it's most treatable. That's very important. Patients often have the misconception that symptoms are when a cancer matters to them. And often it is the exact opposite, that when symptoms happen, complete cure is often not possible. An important question within screening is men over the age of 70. Guidelines state that men should be screened, depending on what guidelines you read, between the ages of 50 to 69 or 50 to 70, 50 to 75. Ultimately, the bottom line is that age, that upper age limit, should be increased in men, certainly who have a greater life expectancy, or certainly in men who, within their goals of healthcare, cancer control and cancer diagnosis is of importance. And this conversation is what we call shared decision making. And shared decision making is a very specific part of screening, and it is well kind of cited in the guidelines. Importantly, the age guidelines should be reduced below the age of 50 for men, again, who have a family history and are of African American race. That age is typically 40 to 45 is kind of when we start to perform the PSA test. The second part of screening or moving on from screening would be the diagnosis of prostate cancer. Just because a man has an elevated PSA does not mean that they have prostate cancer. Similarly, just because a man has a nodule on a rectal exam, which is the second most important part of screening, that does not mean they have prostate cancer. Today, the diagnosis of prostate cancer is more nuanced than it ever used to be. I think historically men used to go immediately to an awake transrectal biopsy under a local anesthetic. That is absolutely not what we do nowadays. We have important, fancier metrics on the blood, fancier PSA tests, I call them, and they come in many different forms. We have MRIs. MRIs are probably the most important adjunct test after the PSA in helping to make a diagnosis. There's genomic testing. And then ultimately there's a more nuanced approach to the nomenclature and to the pathology so that we understand if one has prostate cancer and how aggressive it is, to help tailor the diagnostic process and avoid unnecessary procedures.